In upper motor neuron testing, within the lower extremity, we're looking for the response to one of three different stimuli: the Babinski, where one creates a noxious stimuli along the weight-bearing surface of the foot, or the Oppenheim, which is along the sensitive bony part of the shin, or the Chaddock sign, where the stimulus is on the lateral aspect of the foot. These responses are graded as either upgoing toe or downgoing toe, not positive or negative. The downgoing toe is associated with a normal flexor withdrawal, and upgoing associated with an immature or injured central nervous system. Spasticity is commonly found in the hamstrings, the long quads, and the plantar flexors. Clonus in the ankle of the patella, the wrist extensors or supinators. The Romberg sign, unsteadiness in a narrow stance. The Hoffman sign, which is the upper extremity analog to the Babinski. Either you flick or you squeeze the third nail bed while you observe the thumb for a flexion response. In sensation testing, we want to make sure that we pay particular attention to the distal end of each dermatome, where there's very little overlap between the dermatomes. A nerve root injury will be best detected here and usually results in a small, indistinct deficit at that distal end of the dermatome. A large, distinct area of numbness is indicative of a peripheral nerve injury and is usually easy to identify. Sharp, dull, or two-point discrimination is more sensitive than light touch. Special care needs to be taken to avoid disturbing hair follicles, as they are different receptors. When we want to enhance the reliability of our sensation testing, we want to minimize the distractions. We want to have the patient comfortable on a stable surface. We want to explain the testing procedure to them. Let them feel what it would be in a normally innervated part of the body, the back of the hand or the thigh, the face. We want to explain their response. Each time I touch you, I want you to say yes, and demonstrate touching them several times. Yes, 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 so that they give you an appropriate response. Don't let them see the testing, and don't test with a normal rhythm. Interrupt your rhythm, put in pauses, and do some comparison with the uninvolved side. In the long track testing for touch, we're attempting to stimulate the Meissner's corpuscles or Pacinian corpuscles and trying to avoid the hair follicle receptors. We'll use tissue, a wisp of cotton, or a monofilament, and that information is being conferred up the spinal cord by the posterior columns or the ventral spinal thalamic tract. Vibration is sensed by the Pacinian corpuscles and travels up the posterior columns. You test it with a tuning fork between 128 and 256 Hertz, and you use that tuning fork on a meaty part of the extremity, avoiding the bone, because the bone will transmit the vibration distally and proximally far from the tested area, leading to inaccurate results. In testing pain and temperature, which are transmitted up the lateral spinal thalamic tract. Proprioception, by means of many receptors within the joints, ligaments, and muscles, tendons, capsules, and articular fat pads, is transmitted through the posterior columns and the dorsal and ventral spinal cerebellar tracts. We owe most of what we know about articular neurology to an English physician and physiologist by the name of Barry Wyke, who did his work in the early 70s. However, it still remains some of the most relevant information for us as orthopedic manual physical therapists. This table summarizes his work and identifies the 5 types of receptors, their structure, location, the nerve fibers that transmit the information from these receptors, their function, and the stimuli which triggers them, and the effects or result from their stimulus. Look for a copy of this in the Documents tab within the course. Sensation testing of the dermatomes was mapped out in detail by James Cyriax many years ago and doesn't look at all like the zebra man that we commonly see on dermatome maps. This representation allows us to see how much overlap is present and what the true distribution of each of the dermatome without the overlap. Peripheral nerve sensation in the upper extremity is shown in this diagram from Blumenfeld. Reflexes are tested in the upper extremity using the following muscles. Unfortunately, the C8 reflex of the pisiform is not particularly reliable or useful, as it is not present in many individuals. Reflexes are graded on the following scale, with 2 being normal, where slight motion is elicited, 0 being an absence of reflexes, and 4+ being a sustained motion, as in clonus, which is most clearly abnormal with respect to upper motor neuron findings. When we test muscles, there's lots of information we can get. We can grade strength with our 0 to 5 scale, as we were taught in PT school by the likes of Florence Kendall and Shirley Sawerman. We can test muscles to identify a lesion within the active structures, or occasionally identify a lesion of a passive joint structure by means of transarticular forces being transmitted through that passive structure by the muscle testing. Muscle testing can also give us information on neural conduction and muscular coordination. Our emphasis in the scanning examination is the information from the selective tissue tension testing and neural conduction. The term key muscle and myotome have different meanings, although they're often used interchangeably. Key muscles are muscles predominantly innervated by a single root level. A true myotome is only innervated by one root level anatomically. When we're testing muscles, we're typically doing so in the limbs, where our muscles receive innervation from 2 to 5 root levels. This may seem just like semantics, but your use of the correct term demonstrates your neuroanatomic knowledge. When we assess motor conduction, the critical aspect that we are looking for is fatigability. When we recruit a muscle, we fire many motor units. If some kind of compromise has occurred within the nerve due to compression, traction, ischemia, not all of those motor units will be available, and there will be a clear-cut decline in strength over a fairly short period of time, a matter of 2 to 7 seconds. In order to pick this up, we need to challenge each individual muscle to that patient's strength limits, which, depending on the patient and depending on the therapist, may require you to obtain significant mechanical advantage. When we assess the motor conduction, we want to ramp up the resistance smoothly, challenging each muscle for at least 5 seconds up to 20 seconds. In order to differentiate fatigability, we can do a series of short, repeated challenges, which tends to elicit the fatiguing response. We typically want to test a muscle in its shortened position, where it needs to mechanically work harder and is not stressed by being lengthened. The exceptions to this are the triceps and the quadriceps, due to their unique mechanical leverage. Our key muscles of the upper quadrant are as follows. There are alternates at the majority of the levels. These are not the only muscles. There is some variation between authors. This is based upon the 40th edition of Gray's British When we begin to reason our neurologic signs and symptoms, paresthesia is often indicative of some kind of nerve compromise by means of compression, traction, or ischemia, but it could also be a systemic process causing the paresthesia. The distribution of paresthesia is not reliable diagnostically. The presence of fasciculations within the muscles are common of a lower motor neuron dysfunction, whereas clonus of greater than 4+ on the scale of reflexes and a positive plantar response or of an upgoing toe or thumb flexion seen with flicking the third finger in Hoffman's sign. Clearly significant upper motor neuron findings would be if 2 or more of these were present. Neurologic compromise forms patterns according to the location of the injury. A peripheral nerve pattern will be seen with that large, distinct area of numbness and a complete motor loss, or one proportional to the damage to the peripheral nerve in that individual muscle. A nerve root pattern or radicular pattern will result in a small, indistinct area of numbness at the distal end of the dermatome and fatiguing weakness of the key muscles, all proportionate to the level of root compromise. The following is a review of dural assessment. The slump test is a very sensitive general test for dural involvement. The positive for the test is a reproduction of the presenting symptoms of lancinating pain into the limb, known as causalgia or radicular pain or neuropathic pain. The mechanism by which this occurs is that the dura is not normally mechanically sensitive to stretch. However, when exposed to inflammation, it becomes chemically sensitized, and once sensitized, it will remain mechanically sensitive for several weeks. It can also be sensitized by infection in addition to musculoskeletal injury. The slump test should be able to avoid movement in the affected area of the spine with modification and tensioning of the dural system from above through craniovertebral flexion or below through ankle dorsiflexion should be able to turn on and off the symptoms. A slump test is only positive if it produces the patient's symptoms. Neural tension or neural tissue provocation was pioneered by Bob Elvey and later adapted and modified by David Butler. There's a variety of controversy on the validity of these tests. There are false positive rates in normal populations. Initially, we were told the key is symmetry. However, more recent research leaves some doubt in whether symmetry is always present in the normal. This diagram shows the relative joint position of the major upper extremity nerves. Butler has developed 4 tests for the 3 nerves of the upper extremity. In class, I'll also demonstrate Elvey's test positions, which are quite similar. There is a typical sequence that most of these tests are performed in. However, the end position is the critical part of the test, and it is commonly varied as to the sequence with which the therapist gets there.